Good afternoon and welcome to the 186th of the COVID calls. This is a daily discussion of the COVID-19 pandemic with a diverse collection of disaster experts. My name is Scott Gabriel Knowles. I'm a historian of disasters at Drexel University in Philadelphia. Today we have a discussion of COVID-19 testing with Shobhita Parthasarathi. Just a reminder, you can catch COVID calls live every weekday at 5 p.m. Eastern Time on YouTube. Just go to the COVID Calls YouTube channel to watch. You can also watch COVID Calls on Facebook Live and on Periscope. You can hear COVID Calls anytime, recorded as podcasts on Spotify, iTunes, Podbean, or anywhere you get podcasts. You can also keep up with COVID Calls via Twitter using the handle @USofDisaster or @COVID Calls. Please do help spread the word and send suggestions for future guests, future topics, and please feel free to suggest yourself as a future guest. As of today, December 11th, 2020, there are 1,589,532 deaths from COVID-19 globally, according to the Johns Hopkins University Coronavirus Resource Center. There are 15,721,790 cases reported in the United States, and there are now a total of 293,633 deaths reported in the United States from COVID-19. That's up from 291,307 reported yesterday. As a way to bring some humanity to the numbers, I've been reading a life story or a story of advocacy for those impacted by the pandemic in some way, and I'd like to continue that now. Headline is, Hull Woman Dies After 3 Negative COVID-19 Tests. This appeared in BBC News, July 22nd. Julie Taylor Broadbent from Hull died in the hospital on the 8th of May, 4 days before her 50th birthday. Her family said they had no confidence in the swab test system and called for a public inquiry into the government's handling of the pandemic. The Department of Health and Social Care, DHSC, said its testing scheme was reliable and effective. The 49-year-old had been admitted to the hospital with a burst ulcer on the 4th of May, but her condition worsened and she was given oxygen therapy as she had trouble breathing, her family said. The following day, while in the hospital, she had her first coronavirus test, which came out negative. Because she was still presenting with potential virus symptoms, she had 2 further tests in the hospital on the 6th and 7th of May that each returned negative results. Jane Taylor Broadbent, 54, said her wife's death was testament that the swab tests were not working. 3 tests and she's not here. She tested negative 3 times, she said. The doctor explained that while she had been displaying COVID-19 symptoms, her results were consistently showing as negative. I want honest answers. I want to know why Julie died. We're getting no answers from the government, really, Mrs. Taylor Broadbent said. The DHSC said all swab tests were assessed as performing to the manufacturer's specifications prior to being deployed, but there was a small possibility of a false negative or a false positive, resulting like any diagnostic test. Quote, testing is reliable and effective. An NHS test and trace has already helped isolate more than 180,000 cases, with no significant rise in cases since the country started emerging from lockdown, unquote, a spokesman said. Julie's daughter, Emma Smith, 26, said she found the response from the DHSC describing the tests as reliable and effective really insulting, actually. The widow said she was campaigning for an independent public inquiry to put things right and have measures in place, so if we do get hit by a second wave, we're in a lot better position. Ms. Smith continued, I would like them to see what they've done, see how much hurt they've caused, and sort it out, quite frankly. The DHSC added, every death from this virus is a tragedy, and our deepest sympathies go out to everyone who has lost loved ones. I'd like to read a second obituary today. The headline for the second one is, Detroit healthcare worker dies after being denied coronavirus test 4 times, daughter says. It appeared in NBC News April 25th by Janelle Griffith. Deborah Gatewood had 2 years to go before she could retire from the Detroit hospital. But Gatewood, a phlebotomist for 3 decades, will never celebrate that milestone. She died April 17th from symptoms related to the coronavirus. Her daughter said that prior to her mother's death, she was denied a coronavirus test 4 times by her employer, Beaumont Hospital, Farmington Hills. Hospitals and states across the county have reported a shortage of swabs and other supplies needed for coronavirus testing kits, as well as delays in securing test results at that time. Kayla Carruthers said her mother started experiencing symptoms in mid-March. Gatewood, 63, drove herself to the hospital's emergency room in Farmington Hills on March 18th, where she requested a test and was sent home. They said she wasn't severe enough and that they weren't going to test her, said Carruthers, Gatewood's only child. They told her to just go home and rest. Gatewood went back to the hospital March 19th, by which time she had developed a cough, her daughter said. So they gave her a prescription for cough medicine, Carruthers said in a phone interview. Her mother's symptoms worsened. Gatewood drove to the hospital again, March 21st, because her fever had spiked, Carruthers said. On that visit, she said her mother was told that she most likely had COVID-19, the disease caused by the coronavirus, but was still not tested. Gatewood went to the hospital for the last time March 23rd. On March 27th, Carruthers went to her mother's house and found her in bed. She was not responding when Carruthers called her name, so she decided to take her mother, who had lost her appetite, to another hospital. My husband and I got her ready, Carruthers said. It was taking her a long time to catch her breath, to take any steps. As they approached the door to leave, Gatewood collapsed. Her eyes kind of rolled back, Carruthers said. She was unresponsive. We got her back to the bed and laid her down. Gatewood was taken by ambulance to Sinai Grace Hospital, where she was tested for the coronavirus. She had a fever of 106 degrees. She had developed bilateral pneumonia and was intubated for more than 2 weeks, her daughter said. Gatewood's kidneys began to fail, then her heart. On April 17th, she was declared dead. Carruthers said what bothers her most is that her mother was not treated well at the hospital where she had worked for 31 years. She hopes that people do not get discouraged from seeking help the way her mother did after being turned away multiple times. If people feel symptoms, go to the doctor. You're the only person who knows how you feel, Carruthers said. If you can't get treated at one hospital, go to another. When she thinks of her mother, Carruthers said there is one thought that lingers. This did not have to happen this way. Okay, I'd like to turn to our conversation today. I've really been looking forward to this conversation, and let me introduce my guest today. Shobhita Parthasarathy is Professor of Public Policy and Director of Science, Technology, and Public Policy at the University of Michigan. Her research specializes in the governance of emerging science and technology and the politics of evidence and expertise in policymaking in comparative and international perspective. She's the author of 2 books, Patent Politics, Life Forms, Markets, and the Public Interest in the United States and Europe, that appeared with Chicago Press in 2017, and Building Genetic Medicine, Breast Cancer Technology and the Comparative Politics of Healthcare, that appeared with MIT Press in 2007. She's currently working on 2 projects. The first examines the politics of inclusive innovation in international development, and the second compares COVID-19 responses, particularly relating to diagnostic testing in the United States, United Kingdom, Singapore, and South Korea. Shobhita Parthasarathy, thank you so much for making time to join me on COVID Calls today.
It's wonderful to be here. Thanks so much, Scott. I'm really looking forward to our conversation.
Well, let's start the way I usually do, just to find out where you're calling from and how the pandemic is affecting you there today.
Yeah, so it's I'm calling from Ann Arbor, Michigan, where, like most of the country, we're experiencing a spike in our COVID cases. We have what our governor has now renamed, I guess, a pause. I think, the framing is interesting, but so we had a pause that was supposed to pause on things like indoor dining, high school, in-person high school, et cetera. That was supposed to expire December 8th. It's now been extended for, I think, 2 to 3 more weeks. So, things aren't great, although I will also say that I was out and about a little bit today, and it was a bit terrifying to see how crowded it was. How much that pause is being really, it's really shaping behavior and activity around at least my community, which my community tends to be more open and supportive of the governor's order. So we'll see what that bodes for the case numbers.
Michigan has really been at the center of the pandemic politics this year.
Yeah.
And I guess, as a state that has urban centers, rural areas, it has college towns, industrial spaces. It's a a microcosm of the rest of the country. I want to get your thoughts a little bit about that. Just, have you been surprised by the vitriol? I mean, a plot on the governor's life and those things that ordinarily would feel like something out of a movie or something. They've been on your doorstep this year.
They have been, and it's both horrifying and a bit distressing at how we've kind of moved on, and not, that is not the subject of front page news constantly. I don't think we know the details of that plot, and we're not talking about it in the way that I think we should be. And I think it's worth noting that plot, of course, came after the famous scenes in our state legislature where people were protesting with guns. We've had multiple lawsuits in the state against a number of the governor's stay-at-home orders. So it has been, and of course, I think that into this soup, you have to include also all of the protests after the election and the spectacle in Detroit. As someone who was a poll worker herself, I had even more, I think, empathy for the folks who were trying to just count votes in the TCF Center in Detroit, and the kind of, the implicit message in a lot of this has been, I think, that for some of the folks who are in the rural areas, that this is not a rural problem. Certainly in the beginning, that was the framing. This is not a rural problem. This is a problem in Detroit. And of course, it's essentially exactly what then also came up again with the election, not surprisingly, right? So trying to create that when, of course, that's not at all the case. And some of our northern Michigan counties are beyond the breaking point in terms of ICU bed capacity. So it's definitely not that, but that's the framing of the debate, unfortunately, in Michigan. And it has, we've become inured to that kind of polarization, which I think is really unfortunate.
Yeah, thank you for that. And particularly that sort of caution that we kind of have to remind ourselves once in a while, like this, not only is this not normal, but it shouldn't be. I mean, the numbers of norms that are being there's a reason those norms are norms in a democracy, in a functioning democracy, albeit an imperfect one. You've been so busy in this time, and I want to just actually start. We have a lot to cover, but I want to actually start. You have a piece in Nature, and the title is More Testing Alone Will Not Get Us Out of the Pandemic. And I just want to give one line from this piece. Everybody should check this out. And you say, after decades of discrimination and mistreatment, communities of color are rational and hesitating to get tested, provide personal information to contact tracers, or download a tracing app. That's just one little piece of what you're talking about here in this article. But it's a nice, concise correction for the idea that testing is the techno fix that will deliver us out of this mess. Could you expand on that a little bit? Because I think that then lays the groundwork for lots of the other themes we want to touch on today.
Yeah, I mean, so much of how this project has evolved has really been around technology and equity and testing and equity. And I think that there are a couple of things that I think are important here. One is that we tend to think about whatever it is, insert the techno fix here, whether it's testing, contact tracing, or the vaccine. We think that somehow having more of it will somehow fix our problem. And what's interesting about this to me is that I remember when I was just a graduate student and starting my research on my first book, which is about genetic testing for breast cancer. And to be honest, in March-ish, it was that made me think, I think I have an understanding of testing. Okay, yes, we were talking then about genetic testing. This is a different kind of testing. But what I remember struck me then was how genetic testing for breast cancer almost stood in for treatment. It was sort of characterized as though if only you knew your risk of breast cancer, somehow that was going to solve the problem. And I think that we, especially because in the US at the beginning, there was this feeling of such scarcity, and that exacerbated, I think, that approach, this idea that, oh my God, we don't have access to this, and this could solve our problem. And So that framing has continued ever since. And that framing is problematic, I think, for a couple of reasons. The first is that, of course, and you were mentioning this in one of the obituaries, in the UK, even the framing, now they're no great shakes either, right? There have been serious problems in the UK, which we've been tracking in our research, but they call it test, trace, isolate. That's what they call it, right? We don't call it that here. We are just like freaking out because we don't have access to testing. So without tracing, without isolation, testing has limited importance, I think. That's the first thing. The second thing is, in some ways, kind of going back on what I said, which is one of the things that I've really started to think about is how testing I keep talking about we, and testing performs different functions for different people. And that's another thing that we haven't been thinking about enough. I think that when I think about testing now and the we and the testing, we often talk about, I can speak for myself, all right? I was originally thinking that I might be able to go home for the holidays, and my strategy was centrally about, okay, I'll take a test before I leave. I'll take a test when I get back. It's an enabling device, right?
Right.
It's an enabling device for lots of people who want to travel, who want to go to school. It's an enabling device for universities. It's a surveillance device for others, right? For public health professionals, for city and state public health departments. It serves a different function. They're less interested in the individual, they're interested in the aggregate. So they're less interested in questions around error, sensitivity, and specificities of the tests, right? There are also folks for whom, and that's, that quote that you read, and these are things we're really disaggregating now because I think that there's a lot of it, but or a lot of different ways you could understand this. But I think that for essential workers, for example, for marginalized communities of color, tests are neither enabling, nor are they sort of a benign form of data collection. They're potentially problematic forms of surveillance that, if they were found to be positive, they could either not have the resources to isolate, not have the resources to take care of themselves if they're forced to not go to work, right? These are devices that can massively constrain their lives and actually even devastate their lives, right? So the relationship that they might have with testing is different. And they may not even have the resources to, there are all of these assumptions embedded in the testing systems too, that some of the folks that we're talking about may not even have those resources. So in a lot of cases, for example, in order to get the notification, you need a cell phone, you need a smartphone, you need,
Sure.
right? All of those sorts of things. So I think,
An address.
sorry, you should.
No, I'm learning a lot. I mean, I was just to say, potentially an address. I mean, there's other things you might have to give up that might immediately put you at risk, or that you just don't have.
And I'll just end by saying that piece came out of that frustration that we were, to use in the lingo of our field, black boxing the test, acting as though it was very simple and we just needed more of it. And in the process of doing that, and here's really where my problem lies, in the process of doing that, we are putting so much into it and we're losing nuance that can actually help us fight the pandemic and address the problems at stake. And that's what I have been very concerned about, that we're not, by not understanding these technologies as meaning different things to different people, as tied to different kinds of social systems, we're limiting ourselves in terms of our opportunities to fight the pandemic.
That disaggregation of what that test means to different people, and being cognizant of the pronoun there, not talk about a we as if there's some national we around test, is really important. And I don't think I've heard anybody state it as clearly as you did just now. I want to linger on that enabling part for a second, because there's a phenomenon there that probably many of us have, and maybe individually we have participated in this, or we know those who have, people who say, I got tested and so now I feel comfortable doing X.
Right.
But of course the tests, if you take a little time to learn about them, and we'll talk about different sensitivity of different ones, but unless you're sort of undergoing continual testing, the way this virus works, you can be asymptomatic for several days before it manifests itself. And so you're spreading it. And that was one of the early findings, medical findings, that I think was deeply distressing to the medical community for this particular virus. So I want to just pick on that piece, which is, there's a sort of a psychological issue here, I guess, in part. Why is it okay for people to feel like, I'm going to get the test, and then that somehow, now they have carte blanche to go ahead and do what they need to do? I've had so many people tell me that, and I've read so many stories about that. And then they go on and they get sick.
And then they don't know where they got it or how they got sick because, oh, I got a test, right?
Yeah.
And these are, I mean, I think there are a lot of reasons for it, but I do think that we don't talk enough, or we're not comfortable enough with uncertainty. And that plays all kinds of roles, obviously, in this pandemic. I think that we need to think as societies about how do we manage uncertainty better, around all sorts of things, but how scientists can communicate that kind of uncertainty, because you're exactly right. I mean, I just a few weeks ago, Elon Musk famously was tweeting about how I got 2 tests and it didn't, I said it was, I don't remember what the exact progression was, but it was, some negative, some positive. And that's a common experience if you have the resources to get multiple tests, I have to remind you, right? So there's a certain privilege in I'm just going to get lots of tests and then but it would be so much better if we said, listen, and I think, by the way, I heard something this morning that made me think this is the same thing all over again, which is that people were talking about the vaccine and they said, we don't yet know, are people are going to be communicable? What does it mean to have the vaccine and then be exposed? People are still going to have to wear masks and socially distance. And I thought to myself, okay, I'm just also, like everybody else, learning about the vaccine. So I don't know about the technical details in the way that I know about the tests. But, which is sort of understandable. We want to be out and about. I really want to be out and about. But the more we put into that positive or negative test result, the less we think about the isolation part, which is, listen, if we isolated ourselves for an X period of time, that would bring the numbers down to a manageable level. And yet we keep saying, no, let's put the burden onto the test. Should be able to tell us something. Because everybody says it can tell us something, just like the vaccine should be able to solve our problem, because that's what everybody's telling us. And I think, it just makes me wonder that those of us who are in these positions and talking to more public audiences, what does that mean for how we talk about the issue? And what does it mean for scientists and physicians? Is there a way? What are the ways that we can dislodge the idea of the techno fix? Because I think this is a clear issue of how problematic it can be.
Well, even as you were saying a moment ago, that the messaging in the UK was test, trace, and isolate,
right?
Which implies all kinds of supports and other knowledge, and a process which presumably the government would help supervise and provide support for. And so you don't have to go too far with this if you bother to look into it, to know that test also, to me, is yet another example of pushing risk onto the individual rather than understanding it as a community-based problem that requires community-based solutions, much of which will need the supervision of government in order to organize. So here you have yet another example where we've been told that the lone individual can take their health care into their hands. And I don't know why I continue to be surprised by that, but here we have manifest yet again that message in the United States.
So I asked my student research assistants to put together flowcharts for the 4 countries that we're studying. And I actually started with the other 3 countries. I started with South Korea because I thought that would be the simplest. and we've now done Singapore, and we're working on Singapore and the UK. And as I've been looking at their work, they've drawn these beautiful flowcharts, sort of, if you're symptomatic, here's the trajectory. If you're asymptomatic, if you're in a care home. And what struck me about those was both the relative simplicity, the fact that it could be captured in a flowchart. I mean, there was some complexity that they're trying to harness in 2 to 3 pages, but you could actually capture this, and you knew where to go and what to do. If you were a symptomatic person, you go, in the UK case, you go to a portal. If you go through the hospital, right? So there's a clear flowchart. We haven't started on the US, which is probably the case I know the best, because there's no flow, right? I mean, there's just, it's a free for all. And we've been trying to get a harness, to sort of harness that for months. And, we've figured out some parts of it, enough of it, but definitely it's every person for themselves. And, to go back to what I was saying earlier, in a system where every person has to fend for themselves, that is where inequality clearly rears its head.
Right.
That's not to say that there aren't inequalities in those other countries, and certainly Singapore is an object lesson in how, you create a national system and then, oops, you forgot that there were migrant workers, right? So, I mean, I'm not suggesting that these aren't places that are suffering from the same things, but that kind of literally survival of the fittest approach that we have to our healthcare system is definitely part of why we're struggling so much. I mean, there's just so much, and of course, the proponents would say, this is, there are people who benefit from this free market. This is, we have many more tests. You have access to much more testing. You don't have to worry about the gatekeeper of the physician. You don't have to, it's wide open. And so you have freedom, to put it in, terms of the 21st century anti-mask brigade. But with the price we're paying for that freedom is a disease that we can't suppress.
I just want to remind folks you're listening to COVID Calls. We're talking today about testing and science and politics with Shobhita Parthasarathi. And I want to actually, so we've mentioned it a few times. I want to give you a chance to maybe go back and say a little bit more about this NSF study, understanding the comparative politics of COVID-19 testing. One of my frustrations, and it's not just me, with the way the pandemic is analyzed, is that it's a series of national stories. We get sucked into the graphics, we get sucked into the globe that shows us, but the definition of the pandemic pushes back against that. That's a tension, I guess, always when we talk about globalization and disaster and pandemics. But you've set out to try to address that and correct that in the design of this study. You just gave us a little bit of a fascinating detail about Singapore, and I've had Zulfikar Amir on, and also Hallam Stevens, to talk about Singapore a little bit on a recent episode with Yansel Kang. Take us inside this study. You started to tell us why you chose those countries, maybe some early findings.
Yeah, sure. So I do comparative research, as you mentioned earlier, and so I always am interested in the comparative lens. I think a lot about how political culture shapes not just science and technology policies, but also scientific and technological development. And in the early days of sort of early to mid-March, I was thinking about this. And of course, that was the moment when we were hearing lots of positive stories about both Singapore and South Korea. And we were, kind of already in our many seasons of discontent. And so I decided to look at Singapore and South Korea. I have a close colleague in Singapore, Monami Badra Haynes, who said that she would do some of the research on in Singapore, and I was also interested because so much scholarship in science and technology studies is especially around kind of these questions, is focused on the U.S. and Europe and the West, and my own scholarship has that flaw as well. And so I thought, this is an opportunity to look at Asia. And so I did that, and I had done research in the US and the UK before, which is why I chose those two places. What's interesting is that over time, my questions change. So I guess that's in my opinion, I think, or my approach, usually that's a good thing. It means that I'm sort of trying to follow the data a little bit. Initially, I was interested in how political culture shapes the development, implementation, and governance of diagnostic testing. And, one of the things that's interesting, I'll talk about a couple of things. One is that, the extent to which the countries were prepared and thinking about diagnostic testing very dramatically. South Korea was thinking about it long before, they had established relationships with the private sector. They had an infrastructure ready to go as soon as they had the gene sequence. Singapore not that soon afterwards, and the U.S. and the U.K. were pretty far behind. We simply didn't have the testing infrastructure. Didn't think it was a priority. We didn't have the ability. I think our traditional approach is to assume that the public health lab infrastructure could handle a pandemic. That assumes that you can control it very early. And we had no expansion capability whatsoever. And so that's where the problem arises. That's why we were sort of for many months kind of stuck, because we could only, you couldn't go much further beyond the public health laboratories for the first couple of months, really. So that was one thing that I thought was that is interesting and potentially might have some lessons going forward.
Can I just ask you one thing about that before you go into the second part, which is the for Singapore and South Korea, how much do you think that had to do with MERS and with SARS and sort of that capacity building, or is that not the right way to think about it?
No, I do think that had, that seems to, at very least, and again, this is right, we're still relatively early in trying to figure this out, but that certainly is part of the narrative that they're telling themselves. And it is interesting because it's not like SARS and MERS, it's not like those are other planets where there's no communication about what happened, right? And this is something that I find fascinating, and maybe we'll tease apart at some point, which is that, we already know from SARS and MERS that there are these coronaviruses. That was the trigger behind the diagnostic testing capability. It seems more centrally connected in South Korea than in Singapore. In Singapore, it's more that it was part of this huge biotech push from, that's many decades old. And it just happened to be that part of it was around infectious disease. They decided to bet on it. So I don't think it's as directly connected to the previous coronaviruses. But nevertheless, there's something interesting about the fact that in much of the rest of the world, there was no recognition that they needed to think about diagnostic testing capacity. So much so that very famously, right, that I believe it's the Johns Hopkins Global Health Security Index, right, that famously said that the US and the UK were the most prepared countries, right? So that obviously people have criticized that for many reasons. It deserves much, much, much more criticism, but it is based not only on, I would say, racist assumptions, but it is also based on skewed understanding and distortions of knowledge flows. Specifically, right? What we can't actually, apparently we can't learn anything from anyone else, even if it might save our lives. Right. So, I think that's deeply, obviously problematic. I would like to think that.
That's so distressing. I'm just lingering on what you just said there for a second, because the implications of that are, there's many options. One is, these are small countries and therefore they're not comparable to the US, so we can't learn from that. Or, which this really bothers me, is that's just there's an Asian way of doing this and we're not going to. I've heard public officials say that, and of course the president has racialized this from day one. I don't want to take you off track, but I just put a pin in that because that is deeply distressing narrative.
No, I actually was going to kind of go in this direction, which is that this idea that, oh, well, those Asian countries, something about who they are and, what their characteristics are that makes them better able to manage this pandemic. I think it is, obviously it's kind of a shocking statement, but well, maybe just to me, I should say, maybe to you, to us, it's a shocking statement. But I think it should force us to think about what is it about our assumptions about ourselves and the world such that we're saying those things? Because I'm pretty sure there aren't, they're not saying those things. What narrative are we constructing also about what countries count and what doesn't count? So Australia is a good example of a country that is, technically in the Pacific, but we consider it a Western country, right? We would say that Australia seems to be doing just fine. Germany seems to be doing just fine. So, the construction of Asia has to fit with our assumptions about what Asians are like. Right. And I think that it's a distraction from and I'm going to say this as a professor of public policy. It is a distraction from thinking about institutions, laws, policies, right? If it's somehow inherent in a society's DNA, then we couldn't have done anything better or differently. And so we just have to, sort of hope that our way is technology. So we will, technology will save us. But we can't, we're never going to be like those countries. They're not remotely comparable, which means that we lose a lot of potential solutions.
It strikes me, I mean, there's two sides of this too, which is that not only do we have the picture of some of these Asian countries that we want to have, in this case, the we is the policymakers who are interpreting this for us, but that also, and you wrote about this as well this year in a piece that you published earlier this year in Democratic Theory called Innovation Policy, Structural Inequality and COVID-19. We also, according to your argument in this piece, which I find compelling, we also have a wrong sense of ourselves, of what the United States is capable of, particularly, and maybe this is, I always wonder about this, if it's sort of the long tail of the Manhattan Project notion, and we hear that all the time. All we have to do is amp up the innovation machine, put those scientists in a room, pour some money in the window, and we're going to be fine. But as you point out in that piece, we have some flawed assumptions, particularly when it comes to allied health sciences, epidemiology, and pharmaceuticals. We have some flawed assumptions about what we're capable of and who's going to benefit by that. Can you say a little bit more about that? Because this gets back to our notion of the COVID-19 phenomena as a producer of inequality in the United States, not just revealing it, but actually producing it.
Yeah, so that's a great question, and I think I as I said, much of my work has been focused on the sort of health innovation, and so I want to think more about how it works in other domains, but certainly I would say back from the Manhattan Project and the origins of U.S. science and technology policy, we tend to adopt a trickle-down innovation approach, right? So we give lots of research funding, we let scientists decide what their priorities are. We assume scientists' priorities are public priorities. We encourage intellectual property protection, also assuming that private sector priorities are public sector priorities. And we think everybody's, the magic happens. Then magic happens. And, it's not only that magic doesn't happen, that the magic never gets to a lot of people that need it, but that the fact that our systems or I should say our innovation is determined by a handful of scientists at a handful of universities who are not demographically diverse um, reflects their priorities, right? So if it reflects their priorities, then and their biases and their values, then it's not clear that that the public's priorities are really reflected. And we've seen a number of cases where technologies actually are problematic either for people of color or for low income people, right? Virginia Eubanks, who wrote this wonderful book Automating Inequality, talks about trickle up innovation, and there what she's saying is that basically it's the worst innovation trickles up, so marginalized people end up being being the experimental subjects of the most problematic innovation. They're rarely those that get access to the best innovation, and they sometimes never get access to the best innovation. I'm saying the latter, she said the former, and I'm sort of putting them together. But in a deeply privatized approach to innovation, like the one that not only that we have in the US, but that we have exported all over the place, it really privileges that approach and an idea that the purpose of innovation is to grow the economy, and with magic assumed to be the relationship between innovation and society. And so in the biomedical space, that's deeply problematic because you end up either with, as I talked about in the Nature piece, technologies that are sort of racially biased in certain ways, or people don't get access to essential medicines. All of these problems emerge because basic questions around equity and justice are not considered in the early stages of the innovation process.
So one of the arguments you make in that piece is that there's a disparity built into the research funding stream around health inequality. And I wonder, I mean, is this sort of like the fact that the CDC doesn't study guns as a factor of health? I mean, what are we talking about here when we talk about health inequalities as literally not in the research stream?
Yeah, I mean, so there has historically been almost no research funding available for health disparities. There's many hundreds of times more funding, for example, for genetics and for genetics research, and that both reflects and reinforces, as you were suggesting before, it reflects and reinforces scholarly inquiry. And so then it's not surprising that you have researchers over the last few months publishing articles that say, hey, maybe there's a genetic reason why lower income marginalized communities of color are getting access to are right. dying more of COVID-19. And then and then people have to, then there's a whole response and everybody has to say, no, you don't, but it's because there's a whole funding infrastructure, knowledge infrastructure behind the fact that that's how they see problems, right? So they see it through genetic etiology. They don't know to see it through health disparities or socioeconomic determinants of health because they're not learning that stuff.
Right.
We are not teaching it. There are no incentives to do that kind of research. And there are not, the same kinds of, you think about in the National Institutes of Health, for example, you have these institutes, right? Allergy and infectious disease, human genome research, mental health, et cetera. You don't have one on health disparities, socioeconomic determinants of health and society, none of that stuff, even though that's clearly important, and that also has to do, I think, it's not just about individual scientists, it's also about social biases and scientific biases against certain kinds of knowledge production, right? We want to quantify and things, we want to study them in the lab. We don't necessarily want to, do interviews or ethnographic observation. And, that all of that is part of the mix here.
Yeah, I think, and that's just to linger on that for a second, it's really powerful because the real downside of that is that I don't think researchers go into the biomedical space of ill will by any means. They go in to save lives, but we're asking them to be scientists, but then also to ask them to be sociologists and historians simultaneously. We need to do a better job. This is just public service for STS. We need to do a better job of articulating our indispensable role that the knowledge, like your books, should play at this moment. I have colleagues in the public health school. I'm sure you do too here at Drexel. Sherelle Barber comes to mind. I've talked to her on COVID calls. I mean, she is one of these people who's doing it all, but she doesn't sleep. I mean, their capacity to do that kind of work I don't know if the center can hold. We're putting so much on those researchers to do both the quantifiable and the qualitative. I don't know what the answer to that is.
So first of all, amen. So you probably know that I co-host this podcast with Jack Stilgo, The Received Wisdom. And one of the reasons why we started that was for this exact reason, is that we think that there's all of this STS knowledge and thinking in the world, and more people need to take advantage of that. But and I have a lot of close colleagues here in the School of Public Health or others, and even in the School of Public Policy, my colleague Paula Lanz, who also does this sort of work. And it is about, we need systemic change. You can't have, you have to have incentives in the university. You have to hire these people. You have to not just sort of be content to go back. I think to link it to where we started, part of the challenge here is that what I think we're implicitly trying to say is that there is no techno fix, right? And that's lucrative. And the fact that, it's simple, it's elegant, right? Scientists and engineers love elegant solutions, right? That's something that they yearn for, but certainly my university, and I'm sure this is true at Drexel too, the lucrative nature of the techno fix is also an important part of the story. Absolutely. Which is that, there's not a lot of interest in saying, hey, wait a second, you have to think about the implications, you have to think about the social dimensions, the ethical dimensions, whatever it is. They want you to patent that test, et cetera, and then sell it. And that's where the incentive structures are. And at universities, certainly like Michigan, our technology transfer office says that is the public good, right? So scientists and engineers who may or may not have any exposure to any of the, sort of sociology or history or ethics of any kind, they say, I want to do public good. My department chair, my dean, the vice provost is saying, in order to do public good, I got to get my technology out there. I got to scale it. How do I do that? I patent and license it. All right, here we go.
Right. But let's stay with that part, because you know a lot about this, and wonder if you could just tell us why doesn't that work? And we're thinking about that particularly this year, and maybe to bring it back to the tests. How has the sort of, if you're saying the sort of general assumption, patent and to market it's a good, it's out there, and then competition will drive the price down. So the more patents and the more products that are out there, the better. Make that research to market process easy. But now you have the vantage point of other countries that you're bringing to bear on this. So speak to that patent part of it a little bit, because that is really sort of sacred territory in the technological space in the US, and you have something to say about that.
Yeah, so I'll talk about the patent piece, and then I'll talk about another case that we, from some of our current research, and I'll try to anonymize the case a little bit, but I think it's instructive, not directly on the patent question, but on the kind of social implications question. So one of the things that's interesting to me about the patent question is that it's part of a whole, and this is, obviously I've written about this in the past, but I'm also thinking about this for some in the future, which is that patents are just a piece or of a broader kind of political economy, I would say, around innovation. And So the assumption is that what your goal is to create something that is patentable, and not just patentable, but assumed in that patentability is something that's commercializable, it's standardized, it's scalable, right? These are all the things that you should endeavor to want. And the problem with that is that invariably the best solutions are not the ones that are scalable, actually. They're the ones that are deeply tied and often community driven, right? So there's a fundamental disconnect between this kind of scalable innovation and actually achieving community goals. And that is not something that we're able to square in any serious way. So you know, this is where I think when we think about patents in the context of testing, I mean, testing patents have not been a significant issue, significant barrier, I think, in the US. And I haven't seen it play a significant role in other countries, but I will say this, in Singapore and in South Korea, the government has such a close relationship with industry and is driving a lot of industrial priorities. It has made me think about how the kind of perceived separation in the US actually makes things worse, because it ends up weakening the government and public priorities and allowing only private priorities to flourish. And then universities, for example, are then beholden to an ethos where they think that they're achieving public good through a private orientation, a privatized orientation. But the other thing, I'll just give you this example that I think is instructive. So there's a university that developed a test, like many universities, and people involved in that test, in developing that test, want to make sure that it is widely available to, you know, needy communities and communities that have a specific need for tests. And this is how, and basically they say, listen, we are engaged in equity work because we are really trying to get these communities to use our tests, right? And our tests are relatively low cost. But those communities that have been identified by these, you know, these test developers as needy, a lot of them don't want the test. And this is a puzzle, right? And you know, we're still working this out. This is sort of hot off the press kind of research that my research assistant and I were talking about. And I thought, you know, and to us, we thought, well, yeah, because to the community itself, the test is more than a test. It's a whole social system. It requires all of this kind of policy, practice, activity, norms. There's all sorts of stuff going on. A testing system that would be feasible for this community, that's a relatively under-resourced community, would have to look a particular way that the innovator doesn't know that they need to know, right? Because they kind of say, I built this innovation and I have good intentions, right? You know, like, why aren't you taking my great invention? And I have seen that sort of thing so many times in my career now.
That's fascinating.
You know, and that disconnect is what I would like to figure out ways to address, because I do think so frequently the innovators are coming from the right place. They do want to make social change. They care about equity and justice questions, but they don't necessarily know to think that, you know,
I just want, that's so fascinating, because, you know, in some countries they have tried to achieve a sort of universal testing at a couple of different moments, but in the United States we obviously haven't done that. So I don't know anything more than what you've just described, but I could imagine in this community you've just been describing, it ties back to something you were discussing earlier, which is like, well, why has our community been selected for surveillance? In other words, rather than seeing it as a way to keep the community healthy, which undoubtedly is probably what the researchers set out to do, it's experienced in a different way. Well, other people are not receiving this. why not? And so in the absence of a national strategy, you have all of these different cultural pockets in which these kinds of very complicated nuances and relationships around the technology must be playing out in real time.
And I would add to that, that's absolutely going on, is my guess. But in addition to that, I think it's so important to remember that in a lot of the countries where we're talking about national strategies, and I know that you've talked to a lot of these folks. I know just last week, or a couple of days ago, all the days run together. You were talking talking about the Scandinavian approaches, right?
Oh yeah.
And in so many of these places, the question isn't, I mean, this goes back to the we can't tech our way out of this. There's something that happens after the test, right? Like if someone has to stay home or they have to isolate, where are they going to do that? Can they actually isolate? Can they stay home? What happens if they lose their job? What happens if they lose their daily wages, right?
Yeah.
So those kinds of questions, when we have privatized our approach and we're like, hey, I got a test. You want a test? Like, I mean, the sort of communities are like, well, you can give us the test, but what are we supposed to do then? Mm-hmm. Right? It's gonna, we've heard over the months about how one of the great concerns in some of these lower resource school districts is that they worry that if kids aren't coming to school, then they are not being fed. They are subject to much more abuse, right? So do they want to have access to more testing that would make it more difficult for kids to come to school? Right? Those are the kinds of questions that, we haven't thought about. Instead, we're like, oh yeah, no more tests, right? And that's, I think, to go back to where we started on some level, I hope that we can learn from this and at least maybe learn from this as publicly engaged scholars, let's say, so that we can put pressure to thinking about these things. I don't know if policymakers themselves will, but it's one of the biggest lessons that I feel like I've learned from all of this.
We're almost up on time, and I very greedily, I want your perspective on a few more things. So maybe I can just get a quick hit. Yeah. So the spectrum of options for tests is sort of mind-boggling, and I don't want you to go through each one of them. But how do you catalog them? Like, how have you gone about building out the typology of what tests are? And I was thinking of this just because I think I sent you this link that in Latvia they have a vending machine tests now. I think that's not the only place. There's everything from that to still the unattainable test, the test you dream of, is described in the United States, which in a lot of places people still can't get them. So everything from ultimate availability to unavailable, and then the many types in between. How are you building out this?
So I think that there are three basic categories of tests. The first is the PCR test. That's the one that's the most common. And it is usually that's the one that involves a gigantic swab and is painful. It's the most accurate, but it is generally not it takes more time. It's not as quick.
Okay.
The second major category are antigen tests. And so the Abbott ID Now is a good example, the one they use at the White House. It is less accurate, but it is quicker. So you're trading off for that. Those are the two main categories of tests. Then the third is the holy grail is the antibody test. It has very poor reliability. It exists in some places, but by and large, it's sort of 50 to 60% reliability. I mean, so, I would never suggest anybody take that, but it is the holy grail in the sense that, or it was, I guess, before. It still is, in the sense that you would then know, you could have some sort of passport that you said, oh, I've had COVID, I'm not going to get it again because I have the antibodies. So those are the three major categories, I would say. If you focus on the question of, that I think are the key questions, which is speed and reliability of the tests.
Right.
Then, of course, you have, for each of those categories, you'll have saliva tests, at-home tests versus not at-home tests, all of that, variation. But for me, that sort of whenever I get confused, because there are a billion, I go back to that basic
I need a
technology.
graphic that I could keep up to help me keep track of these. And I wanted to ask you also, I mean, this has been such a strange year in so many ways. We don't usually hear the president of the United States making sort of STS news every day. But, you know, the fact that he has talked about testing incessantly, I guess I just want to, like, what do you do when he comes out again? And he said this so many times over the summer. Oh, testing, we shouldn't test because test reveals more cases. And and I would hear that, and I would, every time I heard it, I would stop wherever I was, and I thought, how is this message being? And of course, people are repeating it. It caught on to a certain, you know, group of the population. We don't really have time for you to unpack all of that, but I guess I'm just sort of curious what you thought of that. It's coming from the White House.
I mean, you know, there's a line from The Princess Bride. I think, I do not think it means what you think it means. Uh,
Right, right,
which is basically
right.
every time I heard that, I'd be
I just
like,
watched that a couple of months ago with my kids. Right on. Yeah.
right? Like that's basically every time I hear that, I'm like, I mean, kind of, sort of, but no, you're just wrong, dude. I mean, I don't. Some people obviously are listening to him and every word, which is deeply distressing, and his racism, especially around the virus, has been dangerous for people.
Yeah.
But um, but I think, yeah.
Yeah.
He leaves me speechless is what I have to say. I don't know that there's really a place to start. And I don't know that, I'm thankful that I won't, that pretty soon I won't have to anymore. I hope, maybe.
Probably so. And thanks to your state for that. Well, I want to just
And
once again
yours.
underscore absolutely the study understanding the comparative politics of COVID-19 testing, Shobita Parthasarathi, and the other work that you've been doing this year. And I really hope that I can get you back, maybe with some members of your research team next
That would
year
be
when you've
fun.
got some more of the work for us to hear about, because obviously we're only in the middle of this disaster. Thank you so much for your time today. Really appreciate it.
Sounds great. Yeah. Thanks, Scott. It was fun.
Just a reminder to everybody, you can catch COVID calls every weekday at 5 p.m. Eastern time. And stay healthy, everybody. Thanks again to Shobita, and we'll see you all on Monday. Thanks.